Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very precious tips which may prove handy in your line of duty. Welcome to part 71 of our Pharmacotherapy MCQ series, which majors in toxicology. The first question reads, which of the listed end products of metabolism would you expect to be reduced in patients who happened to be chronic alcoholics and deficient in thiamine? Is it nitric oxide? Is it ATP? Is it pyruvate? Or is it cholesterol? I'll give you 10 seconds to choose the correct answer. B is the correct answer. ATP it is. Now, chronic alcoholics are at a high risk of being deficient in thiamine, that is vitamin B1, and this is clinically relevant as thiamine deficiency in this patient population is known to put the patients at an increased risk of Wernicke's-Korsakoff syndrome, which is a cerebellar degeneration, and there is also cardiovascular dysfunction involved in it. Now, if left untreated, these complications can result in irreversible damage to several parts of the central nervous system. So you have to intervene promptly. One of the most important sets of metabolic reactions requiring the availability of thiamine includes the reactions involved in glycolysis and the TCA cycle, the tricarboxylic acid cycle. Now, there are three enzymes that facilitate several functions involved in these processes that require the presence of thiamine phosphate. These enzymes are the alpha ketoglutarate dehydrogenase, the branched chain amino acid dehydrogenase, and even the pyruvate dehydrogenase. Now, the forward movement of glycolysis and the TCA cycle are essential for the cell's ability to generate ATP, which is needed to maintain other cellular activities. Now, the current standard of treatment for such patients is to give them 100 milligrams of IV thiamine before administering glucose containing IV fluids. After that, you can continue this dose for several days. Now, the inability of the pyruvate to enter the TCA cycle causes the cell to convert the pyruvate to lactate or lactic acid in order to be able to maintain glycolysis at a minimum rate. Therefore, if you feed the cell more glucose without giving it the needed thiamine to allow for the forward movement of the cellular reactions to complete ATP generation, you only increase the amount of lactic acid produced. Now, the development of acidosis and the inability to form or to follow the pentose phosphate pathway to protect the cell from reactive oxygen species causes damage to cell structures, and this mounting stress on the cell overall results in either cell death or even activation of apoptosis. So it can be very dangerous. Don't ignore these alcoholics intervene promptly by giving thiamine, as I've just explained above. Let's move to the next question, please. And it reads, RAG, a middle-aged patient, is rushed to your accident and emergency department. Now, although this lady is actively vomiting, she is conscious and doesn't have any other GI symptoms. She was found 30 minutes ago by her mother after having swallowed a full bottle of Glyburide XL, an extended release product. So my question to you is, which of the clinical scenarios listed below is an indication for whole bowel irrigation use in Mrs. RAG's case? Is it vomiting, or is it ingestion of sustained release agents, or is it confirmed ingestion of an agent within an hour, or is it airway can be protected? I'll give you 10 seconds to choose the correct answer. The correct answer is the fact that she ingested a sustained release agent. Now, whole bowel irrigation is indicated for cases where long-acting or sustained release formulations are ingested. It isn't recommended for overdose unless the product ingested was sustained release in nature. I'm just repeating that to emphasize. Now, whole bowel irrigation and activated charcoal, as I said earlier, shouldn't be used together, since whole bowel irrigation will decrease the efficacy of the charcoal. It will pass away through the gut quite fast and fail to absorb or adsorb the toxin that you'd like to absorb. Now, we should also avoid the use of whole bowel irrigation in cases of ileus, as I said earlier, bowel obstruction, and even, if I remember well, toxic megacolon. It could complicate issues in such patients. I would like to add that activated charcoal should be used within an hour of confirmed ingestion of an agent, and it can only be used if the airway can be protected and if the patient isn't actively vomiting or isn't nauseous, and when there is no evidence of GI obstruction or even a risk of perforation. So all those many ones justify why B is our correct answer in this particular case. Let's move to the next slide. And it reads, Mr. PBK, a 38-year-old male patient, is rushed to accident and emergency department by an ambulance after an unsuccessful suicide attempt in which he swallowed 90 tablets of lithium carbonate immediate release 300 milligrams. He has vomited once prior to presentation at your accident and emergency department, and there are visible fragments of the tablets in his vomitus. PBK is currently awake, alert and oriented, and all his vitals are within normal limits, and the appropriate lab samples are drawn, and the nurse is getting ready to do an EKG or an ECG. The clinical team is discussing GI decontamination as a modality of intervention in this poisoning management. So my question to you is, which of the options listed below would you recommend they use in Mr. PBK's case? Would you suggest the use of sodium polystyrene sulfonate? Would you recommend to them that no GI decontamination is indicated here? Or would you recommend they use activated charcoal slurry? Or would you recommend the use of polyethylene glycol? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. No GI decontamination is indicated here. Remember, lithium carbonate isn't adsorbed or absorbed by activated charcoal, and therefore charcoal isn't the recommended mode of intervention unless there is a strong suspicion of co-ingestants that may be absorbed by charcoal. That is in cases where you suspect he tried to commit suicide with lithium and something else that can be absorbed by charcoal. Remember, activated charcoal isn't without risk. Aspiration can occur, pneumonitis can occur, ischemic colitis has been associated with charcoal products, especially those containing sorbitol, so be very, very careful. Charcoal is not the answer to all forms of overdose. Now, whole bowel irrigation with polyethylene glycol is only suggested if there has been a life-threatening overdose of extended release lithium and the patient has a functioning gut. Those are two conditions that must be met. And then sodium polystyrene sulfonate is an exchange resin that may reduce lithium levels. It also reduces potassium levels, and this could potentially worsen cardiac conduction, and it's not recommended in this particular case. You would end up with arrhythmias. Now, lithium is a monovalent cation. Lithium carbonate is clinically used in the treatment of bipolar disorder. That's just to remind you. And it has a very narrow therapeutic window of between 0.6 and 1 millimole per liter. And chronic toxicity can develop despite normal therapeutic levels. So remember that. Now, in acute overdose, a useful tool in predicting the lithium concentration is for every 300 milligrams of lithium carbonate ingestion, the level should be increased by 0.1 to 0.3 millimoles per liter. I'd like to remind you that hemodialysis may be used to enhance the elimination of lithium in such cases of toxicity, just as a by the way. So in this case, I would discourage them from doing GI decontamination. Our next question reads, which of the mechanisms of action listed below apply to diltiazem or verapamil with regard to cardiac physiology? Is it reduction of remodeling of the myocardium? Is it increased dromotropy? Is it reduces ionotropy? Or is it increased chronotropy? I'll give you 10 seconds to choose the correct answer. So it reduces ionotropy. Now, both of these non-dihydropyridine calcium channel blockers depress automaticity of the nodal cells, and that leads to reductions in dromotropy, chronotropy, and ionotropy. Now, they competitively and reversibly inhibit calcium entry into the cardiac myocyte by blocking the L-type voltage-gated channels, specifically in the SA and the AV nodes. Now, dromotropy is the rate of AV nodal conduction, that is to say the speed of action potential through the AV node. Chronotropy is the rate of firing of the SN node, which affects the pulse or the heart rate. Ionotropy is the force of contraction of ventricular myocardium. Now, just like to add that lucitropy is the degree of relaxation of the ventricular myocardium. So just like to remind you that both of these calcium channel blockers, diltiazem and verapamil, don't reduce remodeling of the myocardium, neither do they protect against sudden cardiac death in patients with heart failure. That's just a by the way. Let's move to the next question, please. would offer this gentleman supportive care. Now, in patients who chronically use benzodiazepines and overdose, only supportive care with ensuring the patient is adequately ventilating and blood monitoring should be provided. Now, flumazenil is an antidote for benzodiazepines when they are benzodiazepine naive and when they've been given too much and they are hypotensive or they are not breathing. Now, glucagon is used as an antidote for beta blocker and calcium channel blocker toxicity, and bromocriptine alternative D is used to reverse antipsychotic induced neuroleptic malignant syndrome. So all those many words make B the correct answer. And I would like to add that flumazenil shouldn't be used in chronic benzodiazepine users as it can precipitate seizures by inducing withdrawal. Be very, very cautious. It works by competitively inhibiting the benzodiazepine receptors at sites where GABA also binds, and it doesn't reverse opioid-induced CNS depression. Just for your information. Let's move to the next question, please. Our next question reads, Mr. CMG, a 45-year-old man is rushed to the accident and emergency department by an ambulance after a Lopresa overdose. He was last seen 2.5 hours ago, and he sent a WhatsApp message to his brother approximately 1.5 hours ago, bidding his brother farewell. He intended to commit suicide. So my question to you is, which treatment modality listed below would be the most effective in Mr. CMG's case? Would you consider doing hemodialysis? Would you administer insulin followed by dextrose IV? Would you do whole bowel irrigation? Or would you inject atropine? I'll give you 10 seconds to choose the correct answer. So I would infuse insulin followed by dextrose. Remember, Lopresa, which is metoprolol tartrate, is an oral beta-1 selective blocker, which is also known to be lipophilic. Underline the word lipophilic. Now, insulin followed by dextrose is commonly used in the management of beta blocker overdose. Now, the efficacy of atropine and its use in beta blocker toxicity is unknown, so I would not opt for it. And hemodialysis may be helpful with toxicity of hydrophilic beta blockers like atenolol or nadolol, not the lipophilic ones. Sorry, yeah, not the lipophilic ones. They are not readily dialyzable. Now, whole bowel irrigation is indicated in the ingestion of long-acting or sustained release formulations such as metoprolol succinate, which is marketed as Tropol XL. So it would not work for this one. Now, being lipophilic, as I said, it would not be readily dialyzable. So I would not go for A, I would not go for C, I would not go for D. B would be my best bet. Remember, beneficial effects of using insulin plus dextrose have been seen in beta blocker toxicity due to the fact that insulin promotes glucose uptake and carbohydrate metabolism to generate energy that is really required during myocarditis. Administering insulin plus dextrose for beta blocker toxicity, I would like to caution you that there is need to monitor glucose levels every 30 minutes and to monitor both potassium and magnesium levels every hour until such a time when such a patient stabilizes. Let's move to the next question, please. And it reads, In which of the following clinical scenarios listed below would the use of Digibend be indicated? Would it be in the case of a patient with the serum potassium levels greater than 5.5 milliequivalents per liter in chronic ingestion? Or would it be a case of serum potassium levels greater than 5.5 milliequivalents per liter in acute ingestion? Or would it be chronic toxicity where digoxin levels are greater than 10 nanograms per ml? Or is it acute ingestion where digoxin levels are greater than 10 nanograms per ml? I'll give you 10 seconds to choose the correct answer. So both B and D are correct. Now, Digibend is most commonly used with acute digoxin overdose, and that is mainly to bind digoxin and to prevent it from distributing into the tissue. It is indicated for patients with acute ingestion where digoxin levels exceed 10 nanograms per ml or serum potassium levels exceed the 5.5 milliequivalents per liter. Now, for acute digoxin ingestion, it's recommended that you give all the 10 vials of Digibend in the packet, while for chronic digoxin toxicity, it's recommended you start with 1 to 2 vials of Digibend and repeat PRN as needed. Now, Digibend is indicated in children who have ingested over 4 milligrams of digoxin and in adults who have ingested more than 10 milligrams of digoxin, or in cases of acute ingestion where digoxin levels exceed, as I said, 10 nanograms per ml, or in chronic toxicity where the levels exceed 6 nanograms per ml. It's also even indicated in the presence of cardiac arrhythmias that cannot be corrected by other treatments, or in cases where serum potassium levels exceed the 5.5 mark in acute ingestion, or in toxicity with plant-derived digoxin derivatives. Now, activated charcoal is reasonable to consider if administered within 1 to 2 hours of digoxin overdose and if the airway can be protected. Now, atropine may reverse bradycardia from vagal effects of digoxin on the AV node, with about 50% of patients showing improvement. I would like to add that sodium bicarbonate may be used if the patient has hyperkalemia and a wide QRS interval. That's just a by the way. Let's move to the next question. And it reads, which of the medications listed below would cause repaglinite toxicity if co-administered with it? Is it omeprazole, a PPI, fluoxetine, itraconazole, or is it gemfibrozil? I'll give you 10 seconds to choose the correct answer. Both itraconazole and gemfibrozil would be the best choices here. Now, gemfibrozil and itraconazole increase repaglinite levels because of an inhibition in the metabolism of repaglinite via the CYP2C8 and or CYP3A4. I would like to start by saying that gemfibrozil increases repaglinite levels 8-fold, since it is a CYP2C8 inhibitor. Itraconazole, on the other hand, increases repaglinite levels 1.4-fold, since it is a CYP3A4 inhibitor. Now, co-administration of both gemfibrozil and itraconazole with repaglinite increase Repaglynide levels 16-fold, so don't co-administer the three together ever. Now fluoxetine is a CYP2C9, a CYP2C19, and even a CYP2D6 inhibitor, while omeprazole is a CYP2C19 inhibitor. Now repaglynide toxicity due to such inhibition caused by gemfibrozil and itraconazole can lead to hypoglycemia. And I would like to remind you that gemfibrozil also inhibits glucuronidation pathways used by statins. Just as a by the way, in case you are doing polypharmacy, pay attention to all those small details. It could be very harmful when co-administered together. Let's move to the next slide, please. And the question reads: an ambulance rushes a male patient to the accident and emergency department with reported sulfonylurea overdose. My question to you is, which of the manifestations listed below is expected in sulfonylurea toxicity? Do you expect metabolic acidosis, hypoglycemia, fluid overload, or liver toxicity? I'll give you 10 seconds to choose the correct answer. Hypoglycemia it is. Now hypoglycemia is the concern associated with sulfonylurea toxicity because of their action on specific sulfonylurea receptors on the pancreatic beta cells, which enhances insulin secretion. Now increased pancreatic insulin release enters into the portal vein, which goes to the liver to decrease the accelerated basal rate of hepatic glucose production, and this leads to reduced plasma glucose levels as well as increased glucose uptake, thereby causing prolonged hypoglycemia. It could be very dangerous indeed. Now fluid overload and liver toxicity are of concern with thiazolidinedione toxicity, and metabolic acidosis is of concern with metformin toxicity. And hypoglycemia from sulfonylurea toxicity typically occurs 8 to 12 hours after ingestion, but can be delayed up to 24 hours, just for your information. So my highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing and for listening to this video. I sincerely appreciate your continued support, your partnership, and your kind collaboration. And I look forward to interacting with you in the next video. Thank you very much.